All right. So we have discussed about the epidemiology and the pathophysiology, some clinical features, and so I think there was a question. So basically, the agenda of this program really was to answer questions. So about gene therapy, as Dr. Nida has said, just me being a geneticist, I would like to add that now we have some trials that are going on. So those of you who are interested in being part of the trials, maybe you can get in touch with me and I can give you more information about that trials and you can try and be a part of it. It is, that being said, it is not very easy to become part of trials that are not placed and based in your own countries. And about a therapy that is cost effective, definitely the answer is that it depends on the stage of the Wilson's disease you are in. If you're diagnosed right in time, the best therapy to do is your penicillamine and trientine. Penicillamine works very well. I have seen very few people who prefer trientine really over penicillamine. So now my job here is to discuss, teach you a little about why does this disease happen, what did we do wrong that we suffered from this disease, how can we prevent this disease to go to another to our children, and how severe is the disease, can we get to know, and is everything related to Wilson's really genetic in origin. So is it really a rare disease? As in India, policy of rare disease has its no mention. So the thing is, Vinod, about rare diseases, it is not like there is no mention. They Wilson's is a metabolic disorder, and in your rare diseases there is a group of rare diseases which concentrates on metabolic disorders. So because the treatment of Wilson is not so expensive, there is no provision for it, right? For it, which is available in the rare disease policy. But definitely it is a rare disease because it is caused due to some alterations in the ATP7 genes. So now the first thing to know is that it is caused by mutations or problems or some variations in the ATP7B gene. So we all carry two copies of ATP7B gene, and a person will have
Veronica,
Wilson's disease.
not moving.
Yeah, that's okay. I'm not trying to move the slide.
Okay.
So a person will have Wilson's disease only if both the copies of that gene, of the ATP7 genes, would be mutated. That is, both the copies of the ATP7 genes, when they are not working, that's when the person will have Wilson's disease. So each one of us will have two copies of ATP7B gene. One we will receive from the father and one we will receive from our mother. So both of our father and mother must be carriers of these disorders. That's the only way we can have a disorder called Wilson's disease. So it is not something that we can change, and it is not something that we can already check for before the occurrence of a first child. So if you are a person who's suffering from Wilson's disease, we can 100% make sure your child does not have Wilson's. If you are a sibling and you want, if you are a parent and one of your child has Wilson's disease, we can make sure that your next child does not have Wilson's by testing that child in pregnancy. So okay, so about this treatment that you mean that 18,000 per month is a costly affair, I definitely agree with you. And I think that if we put this up for the rare disease program, we can get this for sure. Also, we know, like, trientine is not the only drug. Penicillamine works as well. So maybe that is another option for people who cannot afford that as well. But definitely it's a rare disease, and for rare disease, everyone who's suffering from a rare disease can get that 20 lakh amount from the government to help them in therapy. So now just viewing the slides a little, my basic message, what I wanted to tell, it has, I hope, reached all of you, that So what role has genome sequencing in playing in Wilson's disease? So now the different types of genetic tests I would discuss, but I don't know how much is it's within the scope of this webinar. So if you are having Wilson's disease, we have to sequence and we have to sequence the ATP7B gene. Now, the ATP7B gene can be sequenced by Sanger sequencing, which is the best method. It can be sequenced by which, and that will cost around 30,000. It can be sequenced by exome sequencing or and genome sequencing. Genome sequencing we do not have to do. We only have to do genome sequencing when we don't know what disorder we are looking for. So for your ATP, for your Wilson's disease, if you know you're suffering from Wilson's disease, then the test of choice is Sanger sequencing. It is not genome sequencing, right? And do not spend unnecessary money. And the test of choice you need to do is Sanger sequencing. So now the epidemiology. So this is the answer to your question. The epidemiology is 1 in 30,000 live births have Wilson's in most of the population. Men and women are equally affected. So coming to the genetics of Wilson's disease, which is caused by mutations in the gene code, which code for ATPase copper transporting beta polypeptide, as we can see here, which is located on chromosome number 13. It is a relatively large gene and it is composed of 21 exons. Now, in Sanger sequencing, we have to sequence each exon separately, and that's why the cost of this test is around 35,000. So, different types of defects have been identified in this ATP7B genes, and over 300 mutations have been identified. So, we have to sequence the whole gene, only then we can know which mutation is present. Once we know which mutation is present, then we can do a prenatal diagnosis or a cascade screening, like look for different family members. So, also depending on the type of mutation, we will know the severity of Wilson's disease, like what will be the amount of copper that will be deposited, or will the brain be more involved than the liver, or and so on. So it depends also on the nature of the mutations. So the frameshift deletions and nonsense mutation that cause the protein to not form usually result in a more severe form of the disorder than mutations which are milder. So in most ethnic groups, either one or a small number of these ATP7B mutations are prevalent, in addition to many other rare mutations. This is one mutation which is one of the most common mutations with an allele frequency of 10 to 40%. That is that I don't know how many of you have your reports in front of you, but at least some of you would have this mutation because it's a common mutation. So compound heterozygous mutations for ATP7G mutations are frequent in Wilson's disease, which makes the genotype-phenotype correlation challenging. That means that, so compound heterozygous means that there are two different mutations present on the two different copies of the ATP7B gene, and each mutation will implicate a different involvement. For example, if one mutation is mild and one is severe, then it would be a moderate sort of a Wilson. So that sort of a genotype-phenotype correlation, that is that the genetic makeup will decide the type of Wilson's one person is going to have. So now we come on to the pathology of the pathophysiology of Wilson's disease. So as we know that if there is increased copper, there would be increased intestinal absorption of copper. And when there is plasma albumin binding that is present, there are two types of disorders that can result. One is the Menkes disease. And when there is a problem here at the ATPase channel, that's when we will have Wilson's disease that is present here. Another disorder that is caused due to copper metabolism is aceruloplasminemia, where there is deposition of iron in addition to copper. So in Wilson's, we know there is increase in the urine copper, there is increase in the free serum copper that is present, and the bound copper is decreased. So this is the how the Wilson's disease will progress. Now, someone asked about genetic mutations and where the genetic defect lies, and in how many percent of the cases will we find these mutations. So the answer is we will find these mutations in about 70% of the cases of Wilson's disease. So the Wilson's disease, as we know, will affect the liver, it will also affect the bone, it will cause anemia, it will cause some problems in the central nervous system, in the heart, and also in the kidney. There is involvement of the kidney in the form of proximal renal tubular dysfunction. So if you're suffering from Wilson's disease, these are the organs that we have to screen for regularly in all of you. And but one thing to remember is that every person's Wilson's will not have affection of all of these organs. It will depend on the type of mutation and the type of accumulation, on the extent of accumulation of copper, which organ is more involved than the other. And the commonest organs to be involved are the liver and the brain. It is more common that in the Wilson that is present in children, the liver is more involved, and when the presentation is in adulthood, the brain is more involved. So we have discussed about some basic clinical features, and if there are any questions about the clinical features or the genetics of Wilson's disease, we can take them now, or we can now proceed to the hepatic Wilson's disease, in which we know that the KF rings are visible in 50% of the patients with hepatic disease, and the hepatic disease is seen in all forms of liver involvement. There can also be an asymptomatic disease. There can be abdominal pain, jaundice, your liver can be enlarged, your spleen can be enlarged, there can be ascites, there can be upper GI bleeding, and someone mentioned about splenomegaly as well due to portal hypertension. There can be peripheral stigma of chronic liver disease and cirrhosis, which have to be looked at, and the mental status changes can also be present. So the hepatic Wilson's can present in all these from asymptomatic to jaundice to hepatosplenomegaly can be present. So children initially present with liver disease. So we know that so L comes before N, right? So when there is a child, and so someone also asked that a parent has Wilson's disease. Should the parents be alert about Wilson? What all should the parents be alert about? So Dr. Nida or Dr. Arora, would you like to answer this question? Dr. Nida, would you like to take this question?
Yeah. Which question? Parents should be alerted. Okay. I think he's asking parents alert about
Should
Wilson's disease.
parents be alert, as in what all should they look
Huh.
for? Yeah.
I think he's asking parents should be alert that they would have Wilson's or not. I think he's asking like that.
So,
I
Mr.
don't
Vinod,
know.
um,
We can unmute him and ask him what is he asking.
so maybe you can answer both the questions.
Okay. Okay, so if daughter has Wilson disease, and if you are thinking that parent can have Wilson disease, then it is very unlikely that Wilson's usually present up to the age of 30 years and very rarely 40 years. So most likely parents are carriers, and then daughter has Wilson's disease. But yes, the siblings, yeah, the other your other children, you will have the chances. And what are the for the things which parents should be alert? So it depends on what is your daughter presentation. Is it hepatic Wilson or neurological Wilson, and age of presentation. So if your daughter is having hepatic Wilson, you should look for give proper chelation therapy and look for the signs which shows that the therapy is not working, which shows abdominal distension, any GI bleed, and she is getting anemic, and she is getting cachexic, not gaining properly height and weight. So you should be more alerted. If she is having neurological Wilsons, then look for his writing, his school behavior. If they are worsening, then there are the chances that she is not getting proper chelation. And other than that, what your doctor says, to follow regular checkups, regular routine 24-hour copper testing, uh, as advised by you 6 monthly, or as advised by your doctor.
Lovely. Thank you, Dr. Nida. Also, in the middle of this webinar, I would also like to thank Mr. Sahil, who is a patient and a warrior of Wilson's disease, who is very active, and he's taken such a initiatives to support everyone. So, Dr. Nida, Dr. Arora, and I are very thankful to him to start this initiative for helping others. And so neurological Wilson is what Sahil is really suffering from. And so neurological Wilson is a little varied in diagnosis as well. So a lot of children who come to us present with change in their handwriting, the rhesus sarcoidonicus, choreoathetosis, that is the abnormal movement, some cognitive impairment, seizures, hyperreflexia, some urinary problems, and autonomic dysfunctions also. There are four distinct diagnostic categories based on patients. Major neurological findings could be, so there is involvement of the basal ganglia, that is the extrapyramidal symptoms, which could be decrease in the movements that they could do earlier. So there is also a group when there are the movements that were present now become abnormal. There could be decrease in the movement or abnormal movement. There could be increase in the tone. There could be tightness that is present also. So if you're suffering or your relatives are suffering from any of this, they should be also. So this is something I'm sure everyone with any knowledge of Wilson's disease is aware of. This is the Care Fisher ring that is present. It is very commonly in 90% cases of neurological Wilson's present, and but still it needs an expert eye to diagnose this KF ring. It will not cause any problem in your vision. It is just to help us in diagnosis of Wilson's disease. So it is observed in 90% of individuals with symptomatic Wilson's disease, also almost invariably present in those with neurological Wilson's, and no longer considered pathognomic of Wilson's disease unless it is accompanied by neurological Wilson's. So it is formed by deposition of corpun in the Descemet's membrane in the cornea. So this is a patient of Wilson's, and basically here we can see that there is abnormal movements of the jaw here that is present, and that's why he has a face like that. So Vinod is asking, once patient is out of the neurological issues, can these issues recur even if the patient's taking all medicines properly? So, Dr. Arora, would you like to answer that, or?
You see, what happens is it depends on the component and the causative factor for injury to the brain. After all, there is no direct relationship between your urinary copper, serum copper, and deposition into the tissues. They do not go hand in hand. It is still possible that if you're not compliant with your medication or if you're not compliant with your diet, you may end up having deposition of the copper in the brain in spite of the fact that the serum copper is normal. So that should not give you a false sense of satisfaction that you have been doing a good job. Stick to the basics of diet, continue your medication. More often than not, you'll be on the right track. But knowing very well that the relationship between the blood level and the tissue copper store is far more complicated and dynamic rather than having a linear blood test and the tissue level. They usually do not go hand in hand. So be on, this is the maximum you can do. Stick to the diet, stick to the medication, have a regular checkup. And more often than not, the person will not be aggravated. If they are getting aggravated, that means there is something wrong down the track, either in terms of your diet, medication, proper dosing, timing of the and other factors.
Okay, thank you. So this is that. Now, except the neurological and the hepatic presentation, do we have other presentations as well? So we do have important manifestations like hematological manifestation. They present, Wilson's disease patient will all have a hemoglobin which is much lesser than their peers due to the hemolysis, that is the breakdown of blood that is occurring, and that supplementation should also be done. They will have some bone related issues, so a good supplementation of vitamin D, calcium is required. Then some cardiovascular issues can be present, so a routine ECG echo should be done. Renal, as we spoke about. So there can be a early onset cataract, so that cataract should also be evaluated repeated annually, and for females with Wilson's disease there can be some little problems with the periods also should be present. So now the staging I will leave, and so this will be the end of my talk. The rest I guess has already been discussed. Thank you so much everyone for your